Hi, everyone, and welcome to today's webinar, Beyond the Basics, Assessing and Managing Burns Across Skin Tones in Older Adults. My name is Marianne Lafleur, and I'm the Clinical Manager for Mölnlycke, Canada. I'm pleased to introduce our guest speaker today, Lindsay Barnett. Since 2006, Lindsay has been a dedicated member of the Foothills Medical Center, beginning her career as a registered nurse in the burn unit. She went on to serve as a clinical nurse educator for 11 years before stepping into her current role as nurse practitioner for the burn program in 2022. In this capacity, Lindsay provides direct clinical care to patients in both inpatient and outpatient clinic, while also playing an active role in teaching and research. Throughout her career, Lindsay has held numerous leadership positions, including president of the Canadian Association of Burns Nurses, co-chair of the Foothills Medical Center Burn Quality Committee, and chair of the Aftercare and Reintegration Committee with the Americans Burn Association. In 2023, she was recognized as a Hero in Health ambassador by the Calgary Health Foundation. Her teaching, research, and quality improvement interests focus on patient-centered outcomes in burn and scar management, acute pain, quality improvement, and advancing nursing leadership. We invite you to submit your questions by typing them into the question panel found by clicking on the Q&A icon along the bottom of your menu. You may submit your questions at any time. We will collect them and address them during the Q&A portion at the end of her presentation. A link to the certificate of attendance will be available in the chat at the end of the presentation. Please click the link to download your copy and complete it with your name. It will also be available in your follow-up thank you email. We also ask you to complete the survey that will appear in your browser at the end of the presentation. And with that, thank you so much, Lindsay, and welcome.
Thank you so much, Marianne. And thank you to Mölnlycke and to Wounds Canada for having me today. And an extra special thank you to all of you for joining us. I'm very excited to give this talk. This is basically a part 2 of what we did about a year ago. So we're going to build on some of the stuff we talked about a year ago and really dive into assessing and managing burns across skin tones and older adults. Not sure. Oh, there we go. So before we get started, just a little disclaimer here that any of the information, images, opinions that I'm presenting today do not reflect those of Mölnlycke. I am a paid presenter or consultant of Mölnlycke, and I'm very grateful to have the opportunity to speak with you today. So the objectives for the presentation are, before we dive into our age group and skin tone portion of the presentation, I would like to review identifying burn depth and defining burn depth. Then we'll go ahead and compare how burn assessment challenges differ across skin tones and age groups. Then we're going to look at applying burn assessment concepts to different scenarios. So I'm going to present a number of different case studies as we move through the presentation, and then define some instances where burn center referral is recommended. Before I do get started too, I would like to just put a little plug out for the Advanced Burn Life Support course that is offered through the American Burn Association. There are many different instructors across Canada as well. And myself being one of them, we are offering a course on July 15th in Calgary. Out in Edmonton, Allison Ziegler and her colleagues offer courses quite frequently. And if you're planning on attending the Canadian Burn Association conference in Ottawa this October, there will be an Advanced Burn Life Support course offered there. So stay tuned for if your centers or if the areas that you're working offer the course, because I do think it's a really nice supplementation. It really does focus on that first 24 hours of burn care and really reminding us that we can't let the burn distract us from focusing on the ABCs, but that once we do secure the airway, that we need to look at how the burn is going to impact that long-term outcome. In terms of burn center referral, it is important too that if you have burn patients out in the community or out in your rural areas, that you're thinking about whether or not the patient needs a consultation or even potential transfer to a burn center. So many of the centers across Canada do use the same guideline that the American Burn Association has put out. I've put a QR code here, so feel free to scan that and take a look at the different referral criteria. I also like how they have summarized the different depths of burn injury and how to calculate TBSA, which we're going to go through today as well. So what factors influence burn severity? So we know that mechanism of injury can certainly influence how bad a burn can be. So the different mechanisms that we'll see are flame injury. So somebody pours gas on a fire and they end up with a flame injury. Maybe they're at a campfire and they just fall into the campfire and end up with a flame injury, or a house fire perhaps. Then next we have scald injuries. I would say in outpatients, this is probably the most common mechanism of injury that we see. And certainly this is the most common mechanism in children as well. Scalds can be in any number of different liquids. So depending on the liquid itself can really influence how severe the burn is. We know that water boils at 100 degrees Celsius. Oil, however, has a much higher boiling point. So we know that a patient who burns themselves with oil is going to have a much deeper burn injury. Next, we have contact burns. So common examples of a contact burn is perhaps a child who touches a hot fireplace, might sustain hands to their bilateral palmar surface of their hands. Chemical injuries, luckily not too common, but certainly something we see too with different industrial chemicals that people use. And those can range from acids all the way to bases and all the way in between. So the severity of the burn does depend on the type of chemical that is used. Next, we have electrical injury. We often refer to the electrical injuries as the grand masquerader. And the reason for this is really what you see on the outside is not what you're seeing on the inside. So patients who sustain a high voltage electrical injury often can have very devastating sequelae from that injury, including the need for an amputation. Lastly, I added friction burns on here as we head into the summer months and people are out on their motorcycles. It's not uncommon for us to see a higher incidence of friction injuries in the summertime as people fall off their motorbikes and get a road rash or a friction injury. The other common etiology here is when we were seeing children who would fall off a treadmill and end up with a friction injury from the treadmill. The other factors that do influence severity of the burn are going to be the duration of exposure. So the sooner we can cool the burn, the likelihood that we're going to stop that burning process and hopefully end up with a not as deep of an injury. However, that can be very difficult depending on the mechanism where the patient is at and their knowledge about how to cool the injury. Next, anatomical location. So as you can imagine, if you look at your hand, the dorsal or the top surface of your hand has much thinner skin than the palmar surface of your hand. So we know that the different locations of the body can also impact how deep a burn is going to be. Lastly, the age of a patient, and something we're going to be focusing more on today. So older patients do lose collagen and elastin in their skin, and the skin just becomes thinner due to these variations in proteins and many other factors that influence how thin or thick the skin is. Children also have thinner skin. Next up is our burn depth. So it's important that we have a good understanding of classifying our burn depth because that's going to give us an idea of how we're going to calculate our total body surface area. So looking at this photo here, you'll see that as we go down through the epidermis and into the deeper layers of the dermis, the burn depth is going to get deeper. So we're going to look at this in more detail, but you can see here that we don't tend to call the burn depth as first, second, third, fourth degree. We like to use the terminology superficial, superficial partial thickness, deep partial thickness, and full thickness. So let's go through each of these now. So for superficial burns, this is not going to be included in our total body surface area. This really includes the epidermis only. If you were to assess this patient, they're going to have some redness or erythema. It blanches with pressure. You should have minimal edema, no blisters, but it can be quite painful. And I'm sure many of us have experienced a superficial burn. Now, how you can think about whether or not the burn is superficial or deeper than that is if you were to touch this area and there's no sloughing of the epidermis, that is more likely going to be a superficial burn. So next up, we have our superficial partial thickness burn. So this is going to include all of the epidermis and then going to extend down into those superficial or papillary dermis. So these burns tend to be pink, they're red, moist, tend to have a little bit of edema, and they commonly do have some blisters. They can be quite painful as well. The good thing about these types of burns is that the wound does close within 21 days. And that's really how we classify this patient of having a superficial partial thickness burn, is that it does close within 21 days. These patients do have a low risk of scarring, but of course our genetic potential is going to play into that as well. The most common reason that, or the most common etiology we see for a superficial partial thickness, I would say, is a hot water scald, but there are certainly many other injuries, including flame injuries, that can present this way. So you can imagine now that if you were to touch this patient, a lot of that superficial layer is going to slough off. And that's really how you can know whether or not this redness is a superficial versus a superficial partial thickness injury. Moving right along, we go into our deeper layers of the dermis. So we're going all the way through the epidermis and into the reticular dermis. And these burns tend to present potentially similar to a superficial partial thickness. Maybe you're going to have some blistering and some drainage as well, but you tend to have a little bit more edema. The area, when you end up debriding the blister away, does not blanch as it would with a superficial partial thickness injury. And these burns do take longer than 21 days to close and are at much higher risk of a thick problematic burn scar. And we'll get into hypertrophic scarring just a little bit later. A common example here is a hot oil scald. Now moving into the full thickness burns, this is where we're going to have burning all through the epidermis and into the dermis and potentially even into the subcutaneous tissue. These burns tend to present as white, black. They tend to be quite dry, charred, and leathery. Interestingly enough, though, for this particular patient, the provider that he initially saw didn't think that the burn was that bad because the color of the burn. So the epidermis and burnt dermis were not removed until he came to the burn center. And then you can see that area of white that had no blanching. And this patient actually had very little pain. Although it's important to note that these patients can still have pain. It's a misconception that full thickness burns don't have pain, because we know that they can occur simultaneously. So it's common for a patient to have superficial burns, superficial partial thickness burns, and full thickness burns all in one, hence why they can be quite painful still. These burns will take a long time to close, if at all, and there's a very high likelihood of forming a hypertrophic scar. Some examples here are an electrical injury, a flame injury, which is what happened to this patient. Chemical injuries can cause quite deep burns as well, or tar. And this is just a table I'd like to present from the American Burn Association that kind of summarizes what we just talked about. So looking at the superficial partial thickness, deep partial thickness, and full thickness, using the old terminology, which I still tend to use with patients, but I do try to tell them about our new terminology, and then looks at the different healing time and whether or not a patient requires surgery. So you can see here that even under full thickness, it says healing time never. I put a little star here because that's not necessarily true. If you have a really small full thickness burn, it will go on to heal. And with many full thickness burns, they will eventually go on to heal. It just the quality of skin is not very good. And we'll talk about that a little bit later. So that seems simple, right? We should be able to wrap up now. Well, it's not, especially for the partial thickness injury. So superficial tend to be pretty easy. Full thickness, pretty easy. It's those partial thickness injury, the superficial partial thickness and the deep partial thickness that are very tricky. And it is important because we need to decide whether or not the patient should have surgery or not. So it's really important to note that burns do evolve and that we have different adjunct tools that can help us make this clinical decision making a little bit easier, because clinical judgment alone is only about 65 to 75% accurate. So at my centers and many other centers, we use laser Doppler imaging to help us determine whether or not a burn needs surgery or not. And important to note there is that the burn has to be scanned within 48 hours to 5 days. So there is a little bit of a window that needs to be done. I think we're going to see a lot more tools, AI tools come out that are going to help us also predict whether or not a patient is likely to require surgery for their burn. So stay tuned. In terms of calculating the extent of the burn surface, we use a number of different methods. And I would say typically in the first, couple of hours when the patient comes through the emergency department, or maybe for you that is working in the community, you might use the Palmer method or the rule of nines as a nice and simple, easy way to calculate the total body surface area. The rule of nines is nice because it divides the body into portions of 9 or thereof, the genitals only being 1%, which helps us to get to that 100%. In the children, the head is going to be a little bit larger, but we won't go into that today. The Palmer method is a really nice one too. So you're looking at the patient's hand, not your own hand, of course, including the fingers, and that is going to equal 1%. So if you look at your patient's hand, you can kind of think about how big their burn is. And then lastly, I did make a note of the London Browder. Most burn centers use the London Browder. It is a more accurate representation of the different portions of the body, but a little bit more complex. So we won't dive into that today, but please feel free to look it up. Okay, so now let's get into what we intended to talk about today. We're going to talk more about skin tone and why is it important to talk about skin tone when it comes to burns, wounds, or infection in general. So of the population, 80% of the world's population are actually ethnic minorities. And there certainly is a lack of understanding and assessment and diagnosis. And furthermore, there's a lack of research on these different populations and how we do assess and diagnose injury. So I'm going to show you this Fitzpatrick scale. And this is one that I just grabbed off the internet. You can Google it yourself too. And there's a number of different examples of the scale. Some of them use Hollywood actresses to help correlate whereabouts they are on the Fitzpatrick scale. But really what it is a classification system that describes how your skin responds to UV radiation, ranging from highly sun sensitive to sun insensitive. It's primarily used by dermatologists to assess cancer risks and to determine safe laser settings. So I certainly use this in my practice, and we document our Fitzpatrick scale when we do laser patients. But I'd have to say I'm not very good at documenting the Fitzpatrick scale on my other patients who come through the burn center. So it's something that I need to improve on. Now, regardless of the patient score, we suggest, and dermatologists would suggest, that every patient on this spectrum should use sun protection to help prevent any skin cancer. So in terms of burn wound assessment, like I noted, I'm not very good at this and something that I believe I need to do better. So when we see our patients in our clinics or in the hospital, we should be establishing a baseline skin tone. So maybe that's taking a photo or deciding where they are on the Fitzpatrick scale. And then looking at those, because once we look at our normal assessment techniques like color, sensation, edema, drainage, and presence of hair, how is that going to impact how we assess a patient with perhaps a darker skin tone? Now, if you're wondering about the presence of hair, the reason why I included that is because we know with as the burn injury gets deeper, the hair tends to be absent, or if you were to grab a pair of tweezers or pickups and pull the hair out, it pulls out very easily. And that usually correlates with a bit of a deeper burn as well. Now, I can say, and I was looking at some photos of some past patients this morning, and as that epidermal layer comes off, many of the burn characteristics are the same. So the burn wound itself, the color tends to be that pink or red or even white. The sensation piece for our assessment still holds true, as does edema and drainage. So not too much changes there. When it becomes a little bit more tricky is those signs of infection. So signs of infection can be a little bit different in our darker tone patients because of those perhaps lack of pigment changes. So, or I shouldn't say that, lack of erythema. So, in our lighter patients, it's easy to see when we have spreading erythema or redness extending beyond the borders of the wound. In a darker patient, sometimes what we'll see is actually a pigment change. Sometimes the pigment will become darker. We're still going to get that warmth. So we need to make sure we're feeling around the area. Same with increased pain. So we know signs of cellulitis or wound infection is often increased pain, is associated with increased pain. And then that edema piece. So the peri wound feels taut, or you're comparing it to the contralateral side and it just looks much more swollen. So I have a couple of cases here where we're going to look at assessing the patient's burn. So this is a 40-year-old female. She was cooking with some hot oil, and this is her on post-op day 2. So she presented to our clinic. We elected to pop the blister here. So you can see around her medial ankle, there's certainly some drainage, some blister that probably is going to pop on its own if we don't do that for her today. So we saved her the mess and popped it in clinic, gave her a prescription for some pain meds so she could take some pain medication when she came for her next clinic appointment, and then dressed the wounds and brought her in the next day. This is her the next day at our clinic. So this is pre-debridement and post-debridement. And I'm hoping you're seeing on your assessment that certainly the wound bed looks quite white with some red. So we would call this a mixed depth injury at this point, right? We know that burns evolve. And on post-burn day 3, this is looking like it has some deep characteristics. If you were to press down on those areas, you're not getting much cap refill. If you were to try to pull out a hair, well, you can't even really see any hairs. So this is looking like a deeper injury. She wanted to continue with a non-operative plan though, and we thought that was reasonable at post-burn day 3, so brought her back on. She came for some cereal dressings, but I chose this photo on post-burn day 8. So here you can see quite a bit of hemorrhagic staining. The wound looks like it's still quite white. It looks like a deep injury. So she was admitted for surgical intervention or debridement and split thickness skin grafting. And we're going to come back to her a little bit later. So just keep her tucked in the back of your mind for now. This is a picture of another patient. This is a young lady who is in her 20s, and she spilled some hot tea on her foot. She presented to a rural emergency department and was prescribed some silver sulfadiazine, and was then followed by a primary care provider in the rural town she was in. She did end up moving back to Calgary. She was just going to school in another city, and then she was seen in our burn clinic on post-burn day 16. So this is her on post-burn day 16. The blister, she ended up having a blister, but it was left intact and the cream was just applied over top of the blister. It wasn't debrided or anything. What you can't see in this picture, and I wish I did have a photo of both of her feet together, is that her foot was about 3 to 4 times the size of her other foot. The other piece was is she was having more pain. There was a lot of extra warmth in the peri wound, and it was quite hot. So, and she couldn't even ambulate when she came to clinic. So she came in via the help of a wheelchair. So you can't see any extra redness. So unless you're able to assess the burn using your clinical skills of, touching the area and really making sure that you're comparing the contralateral side, if at all possible. So I may have not noticed how swollen the foot was. I think I would have, but it really was impactful to see the other foot. So we knew right away we had to treat her for infection. We got rid of the blister hood there. And this is what the area looked like. I think you can appreciate the swelling a little bit more in this photo where you can't even really see her lateral malleolus in the picture. But luckily, a lot of the burn was closed beneath this blister, but certainly showed some signs of infection. So we did treat her. And this is her on post-op or post-burn rather. She did not have a surgical procedure post-burn day 22. So she just has a little tiny open area that does go on to close. I unfortunately do not have a photo of that. So you might be wondering, what about the scar? What's going to happen to that area that's open? What's going to happen to that pigmented area? So what is a hypertrophic scar? So this is a scar that tends to present as a thick, puretic, so itchy, a dyschromic, meaning it's got color variations. It tends to be raised, inelastic, and can be painful. And what you'll notice in this photo here is that, yeah, you've got some areas that are red, kind of some brown areas, some whiter areas. It's not uniform. So it can certainly look different based on the patient's presentation. The other thing that's important to consider is that individuals with darker skin tones have a higher risk of hypertrophic scar. And we certainly do see this in our practice. I wanted to show this picture as well. So this is a photo of melanocyte migration. So as the patient's pigment starts to come back, you can see we get these little dots of pigment. Now this can take a long time, like I'm talking months. So we know that keratinocytes, they turn over every 2 to 3 days. Melanocytes is about every 100 days. So we're looking at a fairly good amount of time before we're going to see all of the color come back. And it might not ever come back completely. You'll see it's coming back around the hair follicles to start, and then it just starts to continue to branch out. It tends to look a little bit darker at first, and then it does pale down over time. So remember that lady that I told you to put in your back pocket. So this is our lady who had surgery. This is her on post-op day 7. And if you could feel the graft, you'd notice that it's well adhered. It's actually nice and flat, and there's really no open areas. The photo on the right is 5 months post-op. Now the graft here it's thick, it's itchy, and it's very stiff. So what we ended up doing for her is taking her for some laser treatment, and she did have compression, and I'll show you the outcome in just a minute. But before I do that, I did want to show you a picture of her donor site as well. So you can see that this can be problematic as well. We know a donor site creates a superficial partial thickness injury. And, when we think about wounds that don't scar, well, this I would consider a scar. This is a deep or deeply pigmented area, but it will tend to lighten up over time. However, there are other treatment options for this as well. So what are those treatment options? Compression for sure. So we use quite a lot of compression in our both inpatient and outpatient settings. We use a number of different topicals, things like vitamin A, hydroquinone can help lighten the scar. It works by inhibiting the enzyme tyrosine, which halts the production of melanin in the skin. So use this quite a bit on the patients. We use something called 5-fluorouracil or imiquimod, which can also help lighten the patient's skin. We also use laser. So when our patients are about 4 to 6 months post-operative or post-burn, we will look at booking them for a laser procedure, and we take them into the operating room and we'll do either carbon dioxide laser scar resurfacing, or soon we will have pulse dye laser available. So the carbon dioxide laser can target the thicker and even hyperpigmented burns. The pulse dye laser is more for the redness and itch. Microneedling is another option for patients, not something we do in the hospital or offer through our burn center, but something that patients can seek through dermatology clinics or different aesthetic clinics, which has shown some benefits as well. We do intralesional injections using mostly triamcinolone, which is a corticosteroid, also known as Kenalog. So we do quite a bit to target those thicker burns. And the other thing that we do quite a lot of is laser-assisted drug delivery. So while we have the patients in the operating room doing their laser, the laser pokes these tiny little holes into the scar. So then after these tiny little holes are there, we will actually slather the triamcinolone or Kenalog over top of the burn, and hope that we get some drug delivery that way as well. We can also use different oral medications to help with some of the side effects of hypertrophic scar. And we can do nothing. And some patients do choose to do nothing and just wait. And that's often what we'll tell patients too, because they can be distressed if the skin is looking different. Sometimes there's nothing we can do immediately. So we'll say, you know what, come back in 4 months. If this is still a problem, if it's affecting you functionally, or you don't like the way things look, please come back and talk to us. And this is our patient 1 year post-injury. So she actually only had one laser treatment and she had her compression. I wish I had more photos of her following up a little bit later, but you can see that skin tone has really paled down, and the donor is not near as dark as it was in that initial photo. It's going to take me maybe too long to go back there, but you can see how much it's lightened up there. So definitely worthwhile to wait, but also potentially pursue other options like laser. Here is another one. This is a photo of a patient who, unfortunately, those melanocytes didn't really come back. And I still see this patient today, and he still has quite a lot of hypopigmentation. And this is a really difficult problem that we don't have really good solutions for at this time. Something that we are trialing is something called bimatoprost or Latisse, which is the serum to help you also grow your eyelashes. There's some weak evidence to suggest that it might help with repigmentation, but no really great options yet. So lots more research needs to be done in this area. So I just wanted to pause there, and you can think about some questions that you might have for hyperpigmentation, hypopigmentation, just skin tone in general, and we'll revisit them at the end of the presentation. Because for now, we're going to keep rolling along and talk about burns in the older adult. So the good news is that there have been many advances in burn care that have led to significant improvements in outcomes of burn patients. The exception, though, is the elderly patient. So unfortunately, their morbidity and mortality has not changed or kept pace with the rest of the population. So burns in the elderly, we're talking about those that are greater than or equal to about 65 years old, and they are often associated with poor outcomes. They represent about 10% of admitted patients. The most common mechanisms we see are patients that are smoking on home oxygen, and unfortunately get a flash burn to the face. Scald injuries are quite common. Patients get into the shower or the bathtub, they have a fall and they're unable to get out and the water is too hot. And then cooking. So certainly those are the most common things that we're seeing at our center and the most common mechanisms that are reported in the literature. Frailty is another important predictor of burn management and outcomes. Now, there's lots of different scales on frailty, and the more frail a patient is, the higher likelihood that they're going to have worse outcomes. So we know that comparing two 70-year-old patients could be very different depending on the patient's lifestyle and their frailty scale, their comorbidities. So very different. And that's, perhaps for all patients. Malnutrition. So as patients age, they tend to not be as hungry, their taste changes. So they end up, maybe not eating as much protein as they normally would or to their requirements, end up with decreased lean body mass as well. Patients, older adults are at higher risk of delirium. The general population is certainly at risk of delirium, especially if there's admission to the ICU. But if you look at the literature, older adults are at much higher risk and often due to polypharmacy or other related comorbidities. Infection is an increased risk for our burn in the older adult. And then pain management can be a challenging thing because patients often don't complain as much pain. And sometimes we undertreat their pain, which can actually lead to a delirium. But if we overtreat them and give them too much opioid, they can also end up with a delirium. So it's a very fine balance. And certainly when it comes to wound healing, this is where it becomes very tricky. As we mentioned earlier, we know the skin gets thinner as we age. So the duration of time that the patient has come into contact with the burn or the substance is going to equal a deeper burn. The skin composition changes, and this also increases the risk of infection and sepsis in our burn patients. So I'm going to present this case here. This is a patient who is in her 90s, and she was post-op day one when she first came to see us, not post-op, rather post-burn day one, and her clothes had caught on fire while she was cooking. She opted not to have an admission. Her family really thought it was important that she stayed home and tried to manage this at home, at least initially. This is the patient on post-op day 8. So as you can see, we have some full thickness injuries here. At this time, we had to really pause and think, okay, this patient would likely benefit from surgery. So what we did is we provided her for different options for operative intervention, including admission to hospital. But knowing that this could be very tough on the patient and the family, she really wanted to be in her own home, and knowing that if we did an operation and knowing that donor site morbidity and mortality in general in this older age patient was pretty high, the family really and patient opted for a non-operative approach. We did give a fairly explicit explanation that we thought this was going to be a patient who was going to have the same outcome regardless, that likely these burns would take her life. This is the patient on post-burn day 21. You can see here the eschar is now off. Looks a bit crappy, but surprisingly, the top areas are starting to heal a bit and looking not too bad. No signs of infection at this point. So here on the left-hand side, this is on post-burn day 33, and we opted to treat her with some topical steroids to try to attenuate that hypergranulation tissue. As you can imagine, we know that steroids can cause an increased risk of infection. So we wanted to make sure we were monitoring this patient very closely. So she did come to the burn clinic every day for her dressings. And we have some fantastic physiotherapies in our outpatient burn clinic that are very creative and doing many different kinds of dressings. And this one seemed to be the most comfortable for the patient at the time. And she was quite itchy during this period too. So this really helped prevent any shearing. Now, I would like to mention here too, so shortly after this, the patient did have some signs of infection. Now, they weren't signs that you would maybe think of. So she didn't have a lot of increased redness. What we saw was more pain, and she just started to feel unwell. So we ended up stopping the steroid, and she did get a course of antibiotics. We didn't want to wait. We wanted to be judicious and make sure that we were starting antibiotics early in this patient population. And she did end up clearing the infection and was feeling better and did not have any further infection for her duration. This is the same patient 9 weeks post-burn. So this is on post-burn day 63. You can see here, it's about 95% closed. So looking pretty good. But unfortunately, the quality of that skin is not very good. So as we had predicted, it kind of opens and closes and opens and closes. And still, even at 9 months post-burn injury, it does still open and close, open and close. But she's still with us today, which I think is quite remarkable. As I mentioned, she had many different dressing regimes. We went from silver and back and Mepilex border, Mepilex AG, Mepilex AG border, and the family even became quite creative in how they approached the dressing. So they started doing a lot of these dressings at home, and now they only come to our clinic every 3 to 4 weeks. So what were some success strategies in this particular patient? Well, although we thought these burns would ultimately lead to her demise, she is still doing okay. And she's in her home environment doing the things that are important to her, her gardening. She reads magazines. She's with her son and really gets to enjoy life rather than her being admitted to a hospital and potentially not being able to go home after that. She eats a vegetarian diet, and she certainly talks about having, or the son talks about very good nutrition. And I think that family support has been the utmost importance in this case. The other important thing is close observation of the wounds and early recognition of infection. So the family has now built up the capacity to provide the wound care and recognize any signs and symptoms of infection. And I think it's, a really interesting case and one that we're looking forward to actually presenting at a future conference. So moving along, I do want to also present one last case here. So this is another patient, an elderly female as well. She's actually about 20 years younger than our past patient, so mid-70s. This is her on post-op day 0. She sustained about an 18% total body surface area burn with scalding of hot water. So she has some comorbidities. Our last patient did not have any comorbidities. This patient does have type 2 diabetes, liver cirrhosis, and some alcohol use disorder. So she was admitted to the hospital. We did end up fluid resuscitating her. Her burns were almost 20%, and that's kind of our cutoff. And then this is her on post-burn day 2. So you can see this is what we would consider, a partial thickness burn. We may not classify it as superficial partial thickness or deep partial thickness. But if you were to assess it, there's many areas that did not have any capillary refill, showing signs of a deeper injury. But what we did do is we went and scanned her. So we used our LDI here, and you can see this is a scan at 3 days and 17 hours. And what you're seeing here in the image, if you look on the image on the left, her head is kind of towards the left and her legs would be towards the right of the screen. And that's scanning the burn image. The image that has the blue and the red. So what this indicates is red is good blood flow. That's what we want to see, is lots of blood flow, shows good healing potential, a burn that's likely to heal within 14 days. Yellow, we're getting deeper, and the burn is likely to be a burn that heals in 14 to 21 days. And as we move along the spectrum, if we're seeing blue, blue is unfortunately bad and a deeper burn that would benefit from an operative procedure. Now, I'll point out too that blue, the normal skin will also show up as blue. And the reason for that is because there is no injury and no inflammation present. So you can see here that this patient had a deep injury. So did end up taking her for surgery on post-burn day 5. And now this is her on post-operative day 5. So she had allografting done. So instead of using her own skin, we opted to use cadaver skin to try to test the wound bed. And I'm very grateful that the team opted for this because all of the allograft was actually starting to slough off, which indicates that it was not a deep enough debridement. So she was taken back to the operating room and had a much better outcome with her autografting. So had we have autografted her first, we likely would have lost a lot of that. So these pictures are on the left-hand side. This is on post-op day 4 autografting, and on the right is post-op day 7. So very nice looking outcome so far. These are slides on the left-hand side here. This is on post-op day 23, so about 3 weeks after the injury. And then this is her following up in the outpatient clinic on post-op day 46. So you can see that the skin grafts actually healed quite well. I unfortunately don't have any pictures of her donor sites, but they also went on to close. And some key strategies we used here were we learned some lessons from a similar patient that we had a couple months prior. So really good nutrition early on. We used allograft instead of going straight to autografting just to make sure we had a really good wound bed before we used the patient's own skin. We ensured that we were doing really good wound care and infection prevention, which I like to hope and think that we do this on all of our patients. But one key strategy we used was human growth hormone. So we did use this on a prior patient too, but we started it after we were starting to see issues with our donor site healing and with graft take. So we started this patient on human growth hormone very early on. And I do think that it really did lead to success of her skin grafts and donor site healing. The other interesting thing is this patient had cirrhosis, and there is some evidence or some trials out there that are starting that human growth hormone may be beneficial in the setting of cirrhosis. So might have got a double whammy here. We also used many delirium prevention techniques, making sure we had good pain control, but making sure the patient was well oriented, had a good day-night routine, and mobilizing this patient early. So trying to make sure that we did not keep her bed rest for prolonged periods. So when she had the allograft and was waiting for autograft, that we had her up, had her walking around so that she did not decondition. I just wanted to include this slide because it just came through my email not too long ago on the different ways that you can secure Mepilex. I think this is a really nice dressing that patients tend to like and think it's easy to apply, it's comfortable, and tends to be an atraumatic removal. So hopefully you've received this as well, or you can look at the Mölnlycke website to look for different strategies in keeping your dressings in place. All right, so that almost brings us to our question and answer period, but I did want to talk about a few take-home messages that I hope you'll take home today, that burn wounds evolve. So what you might see on the first initial presentation on post-burn day 0 or at the time of injury or shortly after or post-burn day 1 or 2 may not be what you see on post-burn day 5. So burn wounds that you think are going to heal might not heal. Assessing burn wounds is challenging, and darker skin tones can be more complex. I also like to say that older adults are a unique population with specialized needs and specialized considerations that need to be taken. So if we need to weigh the benefit of potentially keeping these patients at home versus in hospital based on their resources and their quality of life outcomes, what's important to the patient. Certainly, we need more research in these specialized populations. I also want to say, when in doubt, ask for help. Look at that burn center referral criteria again. If you're worried about the patient, the best thing to do is to call. Call your closest burn center, call a friend. It doesn't necessarily mean the patient has to come, but if we can have a look at them and talk about them, then perhaps we can provide some guidance, and maybe it is an admission to the burn center. I use a number of different references here. Kind of wanted to point out the two key ones that I used. Dr. Mark Jeske and colleagues met about 6 years ago at the State of the Science Burn Research Symposium that was really instrumental, I think, in getting this publication out. So encourage you all to read this one on burns in the elderly. And then the other one that I really liked was the Wounds International Wound Care and Skin Tone document here. That's what you're seeing for the lower QR code. The top QR code is going to be the Wounds Canada Prevention and Management of Burns. So I'll give you a second if you want to scan those QR codes. And you can also just Google these things and they'll come up, but great resources out there. And I just wanted to say thank you again for having me today. I'm going to be looking forward to some different questions from the audience. I wanted to give a shout out to my own burn center who just became ABA verified. This is a pretty exciting opportunity for our center. We're one of 4 now in Canada. So Edmonton also has a verified burn center, and then Sunnybrook in Toronto and Sick Kids in Toronto. And now we're going to go to any burning questions you might have. And I'm going to go back to the take-home messages slide while we talk about some different questions.
Thank you so much, Lindsay, for such a great presentation. There are some people who just commented on there saying what a great presentation it is and thanking you. And we do have some really good questions. And as a reminder, you can still submit questions at this time. So one of the questions, and this is actually a question I had myself, is what is the guidance you have on de-roofing versus not de-roofing a blister? Because we were always told, do not ever pop the blister. So how do you make that decision on when you're going to do that?
That's a really good question. So there's 2 trains of thought when it comes to blisters. One train of thought is leave the blister. It has some really good healing properties, acts like a biologic dressing. There's another train of thought that says the stuff in the blister fluid is really bad. It has circulating cytokines that can lead to decreased healing. So what we do we actually think you should pop the blister, but it doesn't need to be done right away. So if the patient's being admitted to hospital and we have lots of good pain control, we want to get the blister off so that we can assess the burn. In the outpatient setting, where we want our patients to be going home and just coming to their clinic follow-up with perhaps not the same level of pain management, we often leave the blisters intact a little bit longer. If it's going to be too big and likely pop anyways, like that one young lady that we had in the presentation, she had a fairly big blister around her ankle. She's going to end up going home. That's going to make a mess of her bed. So we pop the blister, let the fluid come out, but don't de-roof the blister. And then over time, you do end up wanting to de-roof that blister because leaving it too long is going to be basically dead skin. We know that dead skin can attract bacteria and lead to an infection. So there's no really right and wrong answer. It's just if you are going to leave the blister, you need to think about how the patient's going to manage it at home. And the other consideration would be the range of motion. So if you have blisters over joints, you want your patient to be able to move. If the blister is too tight that they're not going to be able to move, then we're going to want to at least pop them. And then maybe in subsequent visits, look at debriding or de-roofing the blister hood. Does that make sense?
Actually, that answered the next question, which was how do you know what to do with the skin after you've de-roofed the blister? So thank you so much for that. One of the other questions we have is how do you decide if you're going to use a silver prophylactically versus for treatment?
Yeah, that's a good question too. And we, tend to use no silver initially in our inpatients, and that's because we're looking at scanning them in those first few days. So we will wait and just use like a daily, even non-adherent gauze dressing until we can scan them. And then we look at putting them in a silver dressing once we've made a decision. In the outpatient, it does depend a little bit on the wound characteristics and how often the patient's going to be able to come to clinic, how large the wound area is, and the kind of risk of the patient. Like, are they a diabetic patient? Is it a foot burn? So location is important as well. How often do we think we'll be able to assess the patient? So I don't have a really good answer. It is very patient specific and tailored to our inpatients versus outpatients.
Here's another interesting question for you. Would you consider a frostbite a burn, or where could that fit in?
I was so close this morning on that mechanism slide that had flame injuries and scald injuries. I almost added frostbite because frostbite is a thermal injury. It's a cold injury, and many burn centers do see these patients. However, their treatment is a little bit different because the mechanism of frostbite is different. And one of the big things with frostbite is we often leave them for a really long time and allow the frostbite or cold injury itself to declare. So it might be months of dressing changes before we look at like surgical intervention or amputation. But the treatment
Wonderful.
is different for sure.
Thank you. Here's one that says, I work in rural home care in BC. Wondering if you have recommendations for product use throughout the progression of burns.
Yeah, again, there's no right or wrong here. It's sometimes even trial and error. So, we might apply one dressing, and as the wound heals, maybe we don't need to do as frequent of dressing changes. Maybe we're looking at, doing a foam dressing versus a dressing that needs to be kept more wet. So it really depends on the wound characteristics and how you progress your dressings. I know when I send patients home, I do also rely on my amazing home care colleagues to assess and treat the burn. So if they find that, oh my gosh, we've been using, let's say, a non-adherent, fairly moist gauze dressing, and it's macerating the area, well, I hope that they will assess and treat the area and then move to a different type of dressing, but always open. Hopefully, whoever the prescriber was as well will be open to helping you make those clinical decisions if it's not something you're comfortable with. I know our home care colleagues will also send the patient back to burn clinic if they have questions, or if it's a patient. I know I had a patient in rural Alberta that was about an hour and a half away. We just chatted through our electronic medical record. She sent me pictures, and we decided together what would be a good opportunity or a good option to change. But I don't have an actual algorithm for progressing the dressing because it really is, again, wound patient specific.
That makes a lot of sense. One of the other ones is, where can they get more resources for burn management?
Mm. So there's definitely through the American Burn Association website is a good one. I would say, if you just the other one is going to be the Canadian Burn Association. I know they're just kind of getting their website up and running, but there's going to be more opportunity there. Attending conferences, reaching out to I think all of the provinces have a burn center or somebody who's specialized in burn. So reaching out to those areas and asking, do you have any burn education available? So we'll often offer different education sessions throughout the year. So certainly opportunities. I know my CNE colleague, educator colleague, and I have offered a few rural education sessions to people in Alberta. So happy to do that for your team if it's something you want. So reach out.
Seems to be that there's so much interest in burns, just the registration alone. So many people want to know more. And your presentation was so helpful. So thank you so much for such an engaging talk. We hope everybody enjoyed this webinar today, Beyond the Basics, Assessing and Managing Burns Across Skin Tones in Older Adults. Please don't forget to click the link in the chat box to download your certificate of attendance and complete it with your name. A follow-up email will be sent next week with an opportunity to view the on-demand presentation, and again with a link to the certificate if you were unable to download it today. If you have any other questions, please contact by email to Wounds Canada. Once you leave today's presentation, a survey for this webinar will appear in your browser, and we would appreciate if you could complete it and provide your valuable feedback to us. On behalf of Lindsay Burnett, Mölnlycke, and Wounds Canada, thank you for joining us today, and enjoy the rest of your day. Thank you so much, everyone.
Thank you, everyone.